Good morning, everyone, and welcome to our latest webinar looking at issues relating to the NHS Long Term Plan tobacco treatment pathway. Today, we are talking about metrics, which are exciting and important, and we're going to find out from Sanjay Agrawal as to why that is the case. I'm Hazel Cheeseman. I'm Deputy Chief Executive of ASH, and I'm going to chair today's session. We are really keen to get lots of questions today. We are likely to have to continue to think about some of those questions, I suspect, and come back to them. And our full intention is to have a follow-up webinar to this session, troubleshooting the issues that people raise and bringing some practical examples of the work that people have been doing, so that we can have a look at those and discuss them and see how they're going. But today's webinar is focused on the national metrics and what those are and the implications of those. So just the agenda is pretty simple for today. We've got Sanjay, who's the National Specialty Advisor for Tobacco Addiction. I'm sure needs no introduction for most of you, who will be taking us through the nationally mandated metrics for each pathway and talking us through that. And then we've got plenty of time for discussion at the end, and we're going to be joined by Paul, the Senior Programme Manager at NHS England, and Tom, who's the Analytical Manager. So hopefully between the three of them we'll be able to pick up some of those questions, and then there may be some things that we need to come back to at a later date. So just a quick bit of housekeeping before we get stuck into the main meat of the webinar. So for those of you that have want to watch this back or have colleagues that might want to watch this, we are recording it. We will make that recording available to everybody, and it'll be up on our webinar page after the event, as will the slides be circulated. Everybody needs to keep themselves muted unless I give them full permission to unmute themselves and turn their videos on, and if you don't, we'll mute you. Please do, as I say, be asking questions through the throughout the meeting, and we'll put as many of them as we can at the end to Sanjay, Paul and Tom. If for whatever reason you can't add stuff into the chat, we have occasionally had a problem with the chat, then do use the admin at Make Reaction email address, or when the update was sent out, you also got my email address, so do feel free to send me questions. If you send me technical questions, I probably can't help you, so definitely email the admin inbox about technical questions. But if they're questions for the session, then do feel free to email me. So I'm going to hand over to Sanjay in a moment, just to take us through the national metrics. Clearly measuring what we're doing on the rolling out these new programs is really, really important. It's important because we need to understand what the impact is of what we're doing, but also these are brand new programs. There's much that's tried and tested about supporting people to stop smoking, but these particular treatment services in these new in maternity, mental health and acute, there are elements of this which are novel, and we're certainly putting them in place for the first time in many of these settings. So it's really important that we understand how they're going, so that we can learn and we can adjust and we can develop our programs, as well as having that kind of aggregate picture nationally about how that's going. And it will also, I'm sure Sanjay will talk about this, really important within our organisations as well to understand what the impact of these programs are, how they're developing, so that we can continue to kind of win over our colleagues as to the importance of this. Again, these novel treatment services, which are many of our, hopefully many people on this call really understand what the value and importance is of having tobacco dependency treatment services in this way. But there will be colleagues that remain either without the knowledge or just unconvinced by the case. And so having the data is really, really important to kind of win our colleagues round to the importance of these services. But even collecting the most simple metrics is full of complexity, and we know this, and that's why we want to have more than one webinar on this subject. I'm sure we'll have the issues around the technological challenges, the human challenges, and the processes and organisational challenges that kind of get in the way of trying to capture even the most basics of metrics. So as I say, raise your questions, raise your examples of things which are perhaps already causing you challenges or giving you pause for thought if you've not quite commenced the work. And even if we can't deal with those today, we will come back to them in a more troubleshooting webinar later. But also, we really want to hear from you. If you've got a solution, a novel way of tackling a tricky issue, things that you've learned in kind of rolling out this stuff within your organisation, we really want to hear from you about those as well, so that the next session that we have can be a combination of troubleshooting some of the challenges that people are finding and showcasing some of the solutions that people are identifying as well. Okay, so I will, without further ado, hand over to Sanjay and we'll get stuck into the national metrics and what those are and what we have to learn from those. So over to you, Sanjay.
That's great. Okay, thanks, Hazel, and thanks to Ash for putting on these webinars and to support everybody working in the field with getting these services available to patients. And metrics is one of the ways that will help us understand what we're doing, how we're doing, are the services effective, and are they helping the patients that we want them to help? And I think that's why we're all here. So could I have the next slide, please? For those of you who maybe are new to the pathway, don't quite understand it, I thought before we go into the metrics that we're collecting along the pathway, it would be worthwhile just talking about the pathway. And predominantly this pathway is about inpatients in acute and mental health settings, but it of course also applies to maternity. It would just be viewed slightly differently to the slide I have here. But firstly, a patient's admitted or admitted to a maternity pathway, as it were, and we need to collect data on who's admitted. Are we capturing all the patients who are admitted who are smokers? So number two is we screen people for smoking, and you'll be aware that there's a whole bunch of definitions about current smoker, ex-smoker, etc. But we screen patients for smoking, and hopefully we prescribe everybody dual NRT on admission to treat temporary abstinence, and we want to record that. Third, we want every patient to see a tobacco dependency advisor on an opt-out basis, and so we need to record the smoking status electronically, and that generates an opt-out referral to the in-house tobacco dependency advisor. Then hopefully the tobacco dependency advisor sees that person within a few hours and starts talking through all of the treatment options to that patient using motivational interviewing, understanding how they've quit before, their level of addiction, and then thinking about with the patient how they're going to be treated and what medications we have and what the behavioural support is for that quit attempt. And in mental health, people of course may be in for several weeks. In acute trust, they may only be in for 1 or 2 days, and so we need to tailor the data accordingly. Next, before the patient goes home, which as I said might be a couple of days, might be a couple of months, we need to make sure that the patient has NRT and medications prior to discharge, so that when they leave home, when they leave the hospital setting, they have those medications, or of course if they're in a maternity pathway, they have the medications, they have the NRT to continue with their quit attempt. And we want to give that patient, that person, their ongoing appointment in the community to continue with their smoking cessation journey. So we like to give them an appointment date and time with a local government stop smoking service. Now, of course, you'll be aware that there are community pharmacists who are now coming on stream to also support the quit journeys of people when they leave acute hospitals, if there's no local government service, depending on what local arrangements are. But we want to capture all that data, when just before the patient goes, do they get medications on discharge, and where are they going to get their care transferred to? What's it going to look like in the community? We need to capture the discharge date when the person goes home, so that we know that the person's gone home and their transfer of care is going on. We want to record if, in fact, they are going to go on to transfer their care into the community, or whether actually their quit journey is going to stop in the hospital at the front door. Then when the patient goes into the community, we want to understand whether the person continued with their treatment plan, and whether they got both pharmacotherapy and behavioural support from the local service. And then finally, we want to record the 4-week quit date from when the person stopped working with the hospital service. So that's the pathway for the patient, and we want to collect data for each of those points, and it's really important because we want to see how effective each of these steps are and help troubleshoot. So can I have the next slide, please? Now, for some of you on the call, you may or may not be aware of how the new NHS service is going to interface with the local government service. So as I said, most people who come into an acute hospital are only there for 2 or 3 days, and the vast majority of their treatment is going to be done in the community. For the vast majority of NHS organisations, acute or mental health and maternity, there is a local government stop smoking service, and so most people will transfer their care to the local government stop smoking service. However, that's not the case everywhere in the country, and some people will continue their treatment with community pharmacists. Some will continue their treatment through the hospital service, and some, for example, the staff offer that we're launching in some areas of staff who smoke, who work for the NHS, they might have a digital application, for example, that is used. And so we need to collect data from all of these providers once the patient leaves the hospital, and then report on those that data and those outcomes. Now, in parallel to the NHS service, of course, the local government services are already there. They're already established in the vast majority of areas in the country. And for each NHS hospital, for example, there may be 2 or 3 local government services. So in my patch in Leicester, we have a city service and a county service, and their stop smoking services actually offer different things to patients. One has a face-to-face service predominantly, one has a telephone service predominantly. And so just be aware that the data that you'll get and the treatment pathway might be different for your patients depending on where they live. So the local government services also collect data on people using their services, and they report them. But with the new NHS pathway, all of this data is going to need to be shared and integrated and used by both the NHS and local government, and that adds that complexity that many of you on this webinar might be grappling with. But we want to make it as easy as possible. We're aware of these nuances, and certainly in my region, it's actually brought people together to think about how we're going to share the data and IT requirements. Next slide, please. So one of the things I did before this webinar was look up the definition of metrics, and here it is. Metrics are the measures of quantitative assessment used for production, tracking performance and comparing. And I thought this definition was really, really helpful. So how does it apply to what we're doing? Well, firstly, we want to, by measuring metrics, we want to see if services are actually up and running, because if a service isn't running, there won't be any metrics. So it will give us an idea of whether these services are up and going in any given ICS or locality. So that's really helpful for us to know. Next thing I want to know is, are all the eligible patients being screened? So in my particular hospital, for example, if 100 patients come into the hospital, are all 100 patients being screened for smoking? Does the system work to capture them as smokers? And that's what I want to know. We can triangulate data with clinical coding there to help us with that. But you know, we want to make sure that this is a service for everybody, not just random 5 people out of 100. So are all patients being screened? And then are they seen by tobacco dependency advisors? Because this is the critical intervention in this program. We have dedicated tobacco dependency advisors who really know what they're doing, who can give patients all of the various options with respect to quitting smoking. And are they seen by these advisors? How many patients opt out? We hope that very few patients will opt out, but it might be that, you know, let's say my service in my hospital has a greater level of opt-outs than a service down the road. Why is that? What can we do differently to engage people more and minimise the number of people opting out? What treatments are being used and not being used? We know that dual identity is really effective for temporary abstinence, and it helps a lot of people quit. Is it being used? And if not, why not? And what can we do to increase pharmacotherapy treatment rates? And are patients getting the behavioural support that works with pharmacotherapy to maximise quit rates? Does the pathway continue after hospital discharge? Because as we know, as I've already stated a couple of times, people are only in hospital for 2 or 3 days. So it's really critical that they have a transfer of care into the community. Is that happening? If not, why not? What can we do differently? Probably the million-dollar question is, does it work? Does the pathway help people to quit smoking? Are we seeing the quit rates that we would expect with a fully implemented service? And the data from that we're going to be collecting will help us with that. Which people opt out? What are their characteristics? Which people opt out right at the beginning of the pathway and aren't seen by tobacco dependency advisors? Which people opt out when they're discharged from hospital and don't agree to that transfer of care into the community? And why is it? And what can we do differently to capture them? Is a programme treating people from the most deprived populations? We know that sometimes when we implement programmes in the NHS, it ends up being that the most affluent, the most able people with respect to, let's say, digital skills or other things, or those who shout the loudest, get the treatments. But actually we know that smoking rates are highest in our most deprived populations, and we want to make sure that this programme is being used by them, and then understand, if not, what can we do to make it better? All of these data metrics could be used for quality improvement so that we make the service as accessible and effective as possible. And finally, we don't want the postcode lottery. We don't want, let's say, people in my hospital getting a worse deal than the hospital down the road, or vice versa. So we want to make sure we limit unwarranted variation, and we can use data to support that. Finally, I'd say that all of the metrics that we're collecting will help us with the overall programme evaluation, understanding cost and benefit, and making sure that there's value for money for the programme and for the taxpayer and for all of us. OK, next slide, please. So one of the questions that you might ask is, well, we're being asked to collect this data, isn't it already being collected? And the answer is a resounding no. It is not currently being collected. None of this data, the biggest single cause of morbidity and mortality in the NHS, we don't collect any data on it routinely up until now. So this is a massive boon for us, that for the first time we're going to collect patient level data. So it's a bit like the birthing of a giant whale of data that we're creating, and what we want to make sure of is not a gigantic belly flop. We want the wiring and the data collection to be as neat as the picture you can see there, especially joining local government services or other community providers. And what we don't want is a fuse box fire with meltdown with this data collection. And that's why webinars like this and the various resources I'm going to show you later on will hopefully be helpful to you to develop the data collection in your area and really maximise this to support quality improvement and data on the programme, so we can deliver the most effective service for our patients. Next slide, please. So the data rows, as you like, the data we're collecting are all numbered, and for those of you who've already got your heads into this, you might recognise some of the question numbers and the data they refer to. But for those who haven't, if you think about the overall pathway, admission, opt-out consultation, the inpatient stay, the discharge, and the completion of treatment post-discharge, well, all of the data questions match up with different parts of the process, and that's true whether it's in the inpatient, acute and mental health setting or in the maternity setting. And so that's how the questions were set up. They were set up to take data points from the pathway that I showed you earlier, or in this slide here. Next slide, please. So I've put some FAQs of mine together that I thought some of you may or may not be thinking, and try to answer them. Probably the first one is, who is responsible for data submission? And I would imagine everybody on this call is sitting on their hands saying, not me, not me. And I can see why. But actually, it is a collective responsibility. So the trust that you're working in or working with has a responsibility to submit this data. But largely the people at the trust and the IM&T department won't know anything about tobacco dependency, and they'll need to understand it. And so they're going to need to work with your tobacco dependency service in your hospital. So that's really important. And then you probably or should have a tobacco dependency steering group, either at an ICS level or at a provider level. And that steering group should be playing a role in this, looking at data submission and working out when it's going to start, who's going to do it, how is it going to happen, how are you going to troubleshoot, etc., etc. And then finally, the ICS are also going to be responsible for data submission, because actually, if we don't collect any data centrally from a given organisation, we're going to be asking the ICS why not. So they have an active role in this too. And it's all of these areas together that need to work together to work out how they're going to submit the data and who's going to submit the data, what particular systems you have in your particular hospital. So the example I'll give is in my ICS, we have a mental health trust, we have a maternity pathway, an LM&S, and we have an acute trust. And actually all three of those have entirely different IT systems. So, and we have two different local government stop smoking services, and we'll probably utilise some of the community providers. So we've got to pull together essentially a wiring diagram of how data is going to be collected in each individual organisation, where the pathway starts, the transfer of data from the NHS provider into the community provider, getting data back from the community provider, and then reporting it through the NHS. And it's actually, you know, a really big task. We've got somebody on it at the moment, and we're hopefully going to start submitting data once we get everything signed off. So, but the point is, it's everybody's responsibility. Everybody has a role to play. Next slide, please. The data submission, when does it begin? Well, actually, it's mandatory from, in fact, this next week, but we fully expect that the vast majority of sites won't be ready. And they won't be ready for a couple of reasons. Number one, they may not have services up and running in their trust yet, because they're still at the point of hiring tobacco dependency advisors, or it's that actually this has only become a realisation in the last few weeks and months, and it's going to take time to set up the IT system, and we fully expect that. We expect a slow rise, i.e. Trust to start providing data, inputting data gradually, rather than it being all or nothing from across the country or any particular trust. Now, what I found in my particular trust is that the letter from NHS England to my trust saying, hey, there's this mandatory data collection from April, what are you doing? Here are the details of where you need to submit the data to. It was brilliant. It helped to focus our service implementation, but it also suddenly engaged our IM&T team, and I got this forwarded email from several different people saying, oh my god, what are we meant to do with this? And so actually it was really helpful all of a sudden bringing IM&T into the fold, who up until then hadn't really wanted to get involved at all. And it also supported our senior management team. Somehow they seemed to respond to the fact that there was an IM&T ask, yet they weren't that engaged when we said, oh, by the way, we want to implement this new service. It was really strange. So I think I would use the data ask as a lever to get engagement from areas within your trust. That's certainly how I've approached this, and it's been very effective, actually. Next slide, please. So what data needs to be recorded? So firstly, there's patient level metrics, so all the things that you might imagine, like their demographics, what type of, whether they came into hospital, what their setting was, where they came in, and why the patients came into hospital, the details of the care episodes, because, if there's a readmission, for example, we need to know the details of each admission, the NHS number that will be pseudonymised, and then of course smoking status. And then there'll be subsequent data on specific parts of the pathway, as I outlined earlier. I'm hoping for some of you, some of the patient level metrics can be pulled into the system from whatever patient administration system that you have in your particular trust. Next slide, please. So how is the data collected in your trust and inputted? Well, that's locally determined. So let's say in my particular trust, I know what IT system there is, and we're going to we're developing the template for the data collection so that we can import as much data as possible, and then it's as easy as possible to input the relevant questions. But every hospital, and there's what, I don't know, 200 plus acute trusts, 50 plus mental health trusts, and then probably another 60 LM&Ss. Everyone will have a slightly different way of doing this. And actually what we'd really like from all of you is to share what you're doing. Hazel asked for this at the beginning, and we'd really like you to let us know, because we want to showcase areas where they've gotten going with this and how they've done the troubleshooting and what you're doing. But equally, we want to share the problems too, because, you know, everybody will have their own problems of and what's going on, but it might be that other people will be able to support and help with that. So please let us know what you're doing to collect data, how you're approaching it, and we want to share. Where is the data submitted? It's submitted via this portal, and Tom, who's on the call with me later, might be able to tell us more about this specifically. How do you register or get access to this portal? And Tom asked me to make the point that this is a managed help desk, meaning that if you have a problem, there are people on the other end that you can contact who will support data input. And it's also secure from an IG point of view. Next slide, please. Will you get feedback on data quality? Because of course the data that comes out is only as good as the data goes in. And the short answer is yes, there will be feedback on data quality, but first we need to be getting data to then work out a process on that data quality. But it is really important for you to get that feedback, I would imagine. Next slide, please. Will you get data reports to you? So, you know, you might think, well, hold on, I'm submitting all this data, but what good is that to me? How can I use that data? Well, we're setting up dashboards. They're currently in development. We're hoping that by around July of this year, you'll be able to view your data from your area on the NHS Futures platform, and then hopefully then use that data for your own quality improvement and your own intelligence as to how your service is doing. And you may use that in conjunction with the other data that you're collecting. Next slide, please. Can you collect additional data? I know lots of areas are collecting additional data that and we deliberately nationally only wanted to collect the absolute minimum data set because we wanted to reduce the burden on people. But we understand that you all might be wanting to collect additional bits of data that support your understanding and your delivery and will support your commissioning, etc. So yeah, you can collect whatever you need to through whatever portals you'd like. Will the data collection requirements change? So this is a really important question because oftentimes people think, well, I'm not going to get started. I don't want to get started on this because, you know, they're bound to change everything. But look, we don't want to change anything unless we really have to. We understand the pain that everybody's going through with this, and we'd only do it after we've gotten a lot of data back, and if we think something needs to change because it's skewing data or we're not collecting something in the way it was intended. So we're not going to change it willy-nilly, but you know, there might be at some point 6 months, a year from now where we need to reevaluate and make a slight tweak. I think that's the last slide, but next slide, please. Yep. OK, so resources. So these slides, the ASH team have, there are lots of resources here with web addresses that you can access. Number 5, I have to say, I think if you're suffering from insomnia, that might be one to keep for another time. Not sure that I would ever read that, but anyway, there you go. Right, so I think that's it with the slides. We're ready for the Q&A, and I've got Paul on the call and Tom from NHS England to help with the questions that people will have.
Thanks, Sanjay. That was great. And there are questions coming in. So we'll just while Paul and Tom are joining, I wonder if you might tell us a bit, because you are obviously involved in delivering some of this out in the field. So if you could talk us through a little bit of your experience in Leicester, while we'll just a few more questions.
Yeah. No, absolutely. So it's been really painful. So our service started over a year ago. We collected data that we thought, would be needed nationally. We pull the demographics from something called Nerve Centre in my trust. We then have to put it on a SharePoint file and share that with our local government service, and that's all done manually. We then have to follow up on the outcomes of those patients, and that's put in manually and then pulled back off SharePoint. So we've collected loads of data, but the amount of administration doing it that way has meant it's pulled out advisors from seeing patients, actually. So it's been really painful, and we have 2 local government services, and that's just my provider trust. So then when we've been ready to work with our mental health and our maternity providers, we realised that it was just from an ICS tobacco steering group. We just realised it was just a behemoth of a task, and so we drafted in our digital solutions logistics expert who might be able to talk at one of these webinars in the future. And I lobbied our chief information officer at our trust and said, look, this is a gigantic problem. What can we do? So he tapped her up on the shoulder, and she's now working through an options appraisal about how we can wire up the whole ICS and what the barriers are and the enablers are, and how to move forward. We also locally bid for some money from our region to support the IT work with an IT project manager and possibly some software updates too. So, I have to say, you can't underestimate this. It's a lot of work. So for those people on the call who are thinking about it now, there's a lead time to this. So the sooner you get started, the sooner you'll get going.
Yeah, that's really helpful, Sanjay. And actually, you nodded to another question that I had at the back of my mind around whether whether everything needs to be done on a trust by trust basis, or are there opportunities to kind of, do stuff at ICS level and kind of maybe try and cut through some of the challenges.
Yeah, I think there will be. And it's keeping everybody sighted on it at the ICS, because sometimes within ICSs things are really siloed. So the acute is siloed from the mental health, is siloed from maternity. So making sure that at an ICS level, and the prevention board is probably the best place, or the health inequalities board, so people are aware of the IT and data reporting requirements.
So we had a question by email, which I'll ask, and then we'll come to the ones in the chat. So we had a question about from Mary Yates about how we can justify collecting and submitting extensive identifiable personal information on tobacco dependency submission document for vulnerable people who have not provided consent for this. I don't know if Paul or Tom want to have a crack at that first. Paul?
I think what I would say is that from the national collection perspective, we have gone through quite a, I would say, severe process of information governance. So we do have we have run through all the information governance requirements for the national collection. It has been cleared through the Data Alliance Partnership Board, and the data provision notice that is available on NHS Digital's website, which is the link that Sanjay said if you want your bedtime reading, does actually cover off which legal aspects we are covered by in terms of the Healthcare Act and the such. What I would say is that the processing of secondary data and the use of patient level data is allowed under those legislations if we're using it to improve services, to do service redesign, transformation, such, and support patients. So we are allowed to collect it. NH Digital actually received the data in through the SCDS portal, and they take that patient level data, and then by the time it gets to us to actually use to do that service transformation bit, it has been pseudonymized, so we can't actually see any of that data. And by the point it comes to us, actually taken into consideration opt-outs and the such, so we would never see that data, and that data would only be held by people who would already hold that data from a acute trust perspective, let's say, where they submit sus data for tariff and the such. So it's all housed within sort of that secure environment within NHS Digital.
Brilliant, thanks, Paul. So we've got quite a few questions about sort of how we might allocate data in different settings. So there's a question, the first question that was posed around, the key point for local government will be when does the trust data become local government data versus whether it stays with the trust. And similarly, people asking questions about where patients are referred into the community for their ongoing care. Does the community service include these patients within their returns, or do they exclude the trust initiated patients? I don't know if Paul or Tom want to come in on, how are we've got potentially, we've got patients in inpatient NHS settings, then maybe coming out into maybe local government settings or pharmacy settings or perhaps another setting. How are we going to track those different patients and make sure we're not counting them multiple times?
I'll come in quickly. I think the honest answer is that we can't guarantee we're not going to double count across different areas. This is one of the things we're going to have to deal with the fact that we're giving local systems the ability to set these systems up differently. In some instances, we're going to have NHS providers doing the whole pathway of care, and so it will all stay within secondary care. In other areas, they're going to be referring people out, or they're actually going to have a mixed model where starts in the NHS and finishes in the local authority. And there is an element of we've got to leave it up to local determination as to how they make that happen, because we can't legislate for every single different eventuality at a national level. We do recognise it is an issue. We do know we're going to need to work with people to thrash it out. What I would say is that people at a local level will know whether they are double counting the data, and if people are actually doing the work, they're going to want to record that data. So when we start to think about looking at dashboards and things, we know there's a certain number of NHS quits and there's a certain number of local authority quits. At a local level, they will know whether or not they are separate or whether they are combined when they're using that, and they're sort of applying that local intelligence to the interpretation. It is something we're just going to have to look and see and work with as we move forward, I think.
Thanks, Paul. So a question about whether there'll be a standard submission for acute maternity and mental health and community stop smoking service. Sorry, standard data submission. I don't know if this is Tom or Paul or.
Shall I take that one, Paul?
Give me a break.
Yeah. So the submission is one template which hopefully will cover all of those different settings. So when you go to the NHS portal, you can download the pro forma, the template which you enter your data on, and that is the same template for whichever setting. Obviously, there's some questions that are left blank depending where the patients come in and what their journey is through that pathway.
Thanks, Tom. And you'd already responded to this, Paul, in the chat around verifying quits at 4 and 12 weeks, but I wonder if you could come back to that for those of you, for those who are not seeing the chat.
That's absolutely fine. For this collection, we're actually only asking for outcome data for the 4-week quits, and we are accepting self-reported quits. We know that there are some algorithms you can apply to that data, recognizing that some people give what they think is the right answer rather than what is the correct answer, but we're not asking for carbon monoxide verified quits at this particular juncture. I don't think we will be moving forward, but local systems can make that decision locally. If they want to work towards a carbon monoxide verified quit, they absolutely can do, but we recognise that it is not something that we're asking for nationally. And
it could be that people locally kind of pursue different approaches there, so you could decide to just do the bare minimum and not have any CO valid verification, but you could do, you could do a spot check, as it were. You could do a grouping and
absolutely
and try to understand how your self-reported quits would reflect if you were doing carbon monoxide screening. So there would be different ways of kind of tackling that.
Obviously, within the maternity environment, we want to work towards carbon monoxide monitoring.
Yeah, of course, because that would be absolutely because that's the, and in fact somebody asked a question about whether in that maternity pathway the expectation would be to carbon monoxide validate at each quarter. I mean, I think that the new NICE guidance would suggest that you should be carbon monoxide screening with monitoring women at each appointment, particularly those who are ex or current smokers. So I would guess that the best practice there would be to CO validate in that maternity pathway. Okay, there's a question about dashboards and whether those will be available to those working regionally to monitor delivery. Tom, do you want to take that one?
Yes, I think the answer is yes. It's just a question of when, and as sort of Sanjay alluded to, the data is just coming in now and we're moving to the mandatory phase. So we have 3 months worth of development of our dashboards programmed in, and then we can assess and see hopefully that we've got to where we wanted to be and have a minimum viable product that we can start sort of socialising with everyone who would like to have a look at it.
And I see, Tom, that you posted in the chat that there's FAQ now live on NHS Futures. So we'll particularly, I think that was on your slide as well, Sanjay, but we'll particularly make sure that we flag to people those resources that will be most kind of useful.
I've put the link to NHS Futures site in the chat as well for people.
Great, thank you. Just there's so many questions coming in. I'm just trying to keep up with them.
Hazel, while you're asking that question, can I ask Tom a question?
Sure, go ahead.
Tom, you know, with that portal on the slide, there's a username and password. So what do people need? Do they need to be given access or apply for access? How does that work with the portal?
They do. They need, if people go to that link, it should ask them to apply, and then we go on and invite people to join. It's a bit of a convoluted process. I'm not quite sure why it's been set up in that way, but somebody will go in at some point today or over the next couple of days and accept people's.
Sorry, I think we're talking about
different things here.
I think, Paul, you're talking about the NHS Futures portal, and I believe Sanjay was asking about the SCDS NHS Digital one.
Apologies.
But actually, both of them is really important because we keep on referencing NHS Futures. So actually, Paul, your answer to that question is fine. And then Tom, what about the SCDS portal?
Okay, so we've done large mail outs based on people who are signed up with SCDS for other data collections. So every trust should have a number of people who have been notified, and they were initially signed up to the tobacco collection. After that, they can suggest other colleagues and get in touch with NHS Digital via the collections email address. And I'll dig that out and put that in the chat in a moment. And if there are any trusts who either haven't got the emails through whichever route that they should have come in, they can use that email address and go directly and ask to be signed up for the tobacco collection.
Yeah, I think that's going to be important because I think that there's going to be a huge disconnect between the names of the people that we have in a trust who are largely going to be based probably in senior management or IT, who have no clue who the tobacco dependence data inputters are or the project managers are. So there does need, it strikes me, there needs to be a separate, there needs to be a very clear way that people working on tobacco dependency services can get into that portal.
I think we envisage that it would be mainly business intelligence leads who would do the final submission via the portal, but they would obviously work with the tobacco team to collect and collate the data into the template ready to go. Contacting the right people has been a challenge. There aren't readily available lists of all the people that we would want to go to directly. So it is a case of putting information out in bulletins. We've also contacted Caldecott Guardians because that is a publicly available list, and asked them to cascade. And webinars such as today are also useful to start those conversations going.
Okay.
Thank you. So many questions coming in, and Ranjani responding to you, Paul, around thanks for clarifying the different reporting, the differences, making the point that the differences in reporting methods, even perhaps within a single system, will make benchmarking across systems and regions quite difficult. I think that seems likely, and I wonder if that's something we could come back to, unless you've got more you want to add to it now, Paul. But I do wonder if that's something that we could come back to and sort of spend a little bit more time thinking about on a future webinar.
Yeah, I think at a population level, it is going to be complicated. Absolutely. However, we are asking all NHS providers to submit the data set for those patients that they are providing services to. So at a certain level between NHS providers, there will be a level of comparability that we will be able to look at, and we're using a common data set. So it's not going to be easy, but even the local authority stop smoking service data set that we have now is not necessarily comparable across different areas. It's not even mandated, so there are areas that don't actually submit to it. So we're not going to be in a worse situation, hopefully.
And somebody also asking about whether the programme will be evaluated. I mean, it's obviously the work that you guys will be doing. Also, we hope to have on a future webinar academic colleagues who are also looking at evaluative approaches, who I think may well have dialed into data listening. So we can come back and talk perhaps at the next webinar about the kind of separate evaluation that might be happening in the kind of academic space. But I don't know if you want to talk a bit more about the kind of evaluation approach NHS England will take.
I think the simple answer is yes. It will be evaluated. We haven't nailed down exactly what that will look like in totality, but we are working in conjunction with some academic partners in the academic research collaboratives. So we will be getting some qualitative evaluation through there. We obviously will have this data set, which will allow quite a significant amount of evaluation locally, especially around return on investment and such. And then sort of some wider evaluation things that we might want to be looking at in terms of long-term benefits and as such, but something that we are looking at but haven't sort of nailed down definitively yet.
Yeah, and it's interesting that you raised the kind of qualitative component there, Paul, because obviously today we're focused on the nuts and bolts of these metrics and the things that you're going to count, which are really important and quite difficult to do. But the qualitative insights, both nationally, but also within your trust, sort of understanding how programs are working from both the professional perspective and from the patient perspective, in terms of like refining and improving and identifying, how the program can be made to improve, will be important for people to think about as well. We didn't want to overwhelm this session, given that the bean counting is going to be complicated enough, but I do think that would be something that we certainly want to come back to. Okay, so maternity, going back to the maternity pathway. For maternity, are you classing the outcomes as the end of the pregnancy or the result of the end of 28 days, as maternity patients are supported all the way through the pregnancy? So what's our kind of outcome point for maternity, Paul?
From a maternity perspective, there's several outcome points. We are looking at, we want to collect data on the 28-day quit, because whether or not the lady is a pregnant woman or not, she's still an adult attempting a quit. We're also wanting to track through the 36-week outcome, as well as the smoking at time of delivery, as and when data quality gets better within the maternity services data set. There might be a couple there that we can switch off, but at the moment we're collecting effectively all three measures, and we'll be able to look at 28 days as well as 36 weeks SATOD, and also the change between booking, hopefully in 36 weeks.
Yeah, really interesting to see. And is there any intention to capture any data about other people in the woman's household? Because there was certainly discussion at certain points of this process about partners, for example.
Yes, it's difficult because they're technically not under the care of the NHS, so they are not a patient, and we cannot request data on them. So the commitment is that we will support pregnant women and their partners. In reality, the way we'll be supporting partners is to look at how we can work very closely with local authority services and such to fast track people in. So that data would potentially be recorded through that route, but we can't request patient level data for someone who isn't a patient, unfortunately, so we can't collect it within this return. We realise that it will mean that we miss out on some work, because there will be areas that support people.
Yeah, I mean, look, this is not necessarily for discussion now, and hopefully we'll come back to it in a future webinar, but I was having a really interesting conversation with some academics who have been working in the neonatal space and wanting to provide intervention to parents in that space, but of course their patient is the baby and not the and not the parents, but they've found some interesting ways of kind of dealing with that.
I've had paediatrics about supporting parents as well. They're technically not within scope of what we're asking for collection.
But of course, as you say, there will be local, local approaches, local solutions, and there may well be that, neonatal units or maternity services find other ways of kind of supporting some of that wider family. Right. A kind of logistic question. If I've missed this, at what level are we submitting? One submission per ICS, one for each hospital trust, mental health trust, maternity service, one per local authority area to include their residents. So what's, I think I know the answer, but I should guess. Tom, what's the answer to that? What's the expectation of the submission?
The answer is it's one per trust.
Good, nice and clear. Okay, so I don't understand this, but I'll read it out. Is it worth implementing a monitoring flag for community services so we can check a box or record that it is from the TDT pathway, or tobacco dependency treatment pathway, and then it can be picked up by quality returns, therefore X amount of our quits are through an acute tobacco dependency treatment pathway? I honestly didn't understand all those words. I don't know if any of you did.
I understand that. I mean, I think what the person is asking is, so let's say you're a local government service. How do you separate out what's coming in from the NHS versus what's coming in through footfall to your local government service, and can you tag it? And I'm sure the answer is yes, but and we're having to do that locally in my trust too, because not only is it about data collection, but it's also things like cross-charging for pharmacotherapy. So it will be in the interests of everybody, well, the local government services, to flag which patients are coming through from the NHS that wouldn't maybe previously have come through. So yes, but that's locally determined.
Yeah, okay, so those are the sorts of things that people need to start thinking about locally, what you want to track and how you can do that within your systems.
Yes.
Yeah, great. Okay, so really good question. Thank you for asking it. I think this is probably linked to the discussion we were having around evaluation, and it may be that the answer is TBC, but Fran's asking around what data is going to be used as the baselines to inform KPIs and milestones. Paul.
Effectively within the NHS, these are new services, so we don't necessarily have baselines within this. So there is going to be an element of, through the evaluation, of recognising that, and probably some building work outside, and moving forward and looking at what happens and how things change over time. That said, there are some bigger data sets that are out there that we can maybe look at the baseline in terms of overall populations and the such, but it's an artifact of a new data collection. We don't necessarily have the baselines here. We do know there are certain areas around the country that have been collecting this for a little bit longer, so there might be something that we can do there in terms of looking at sort of little snapshots of what's happening, such in Greater Manchester, and we know they've already gone ahead in South East London, so we might be able to do something there to look at sort of overall trends. But realistically, for the vast majority of people, this is new data, and we'll have to generate the baselines as we move forward.
There's a few kind of questions coming out around who's going to be funding what. I mean, that's not strictly what our webinar is about today, but I don't know, Sanjay, maybe you might address it. So with the funding for 12-week NRT provided as part of the long-term plan for pregnant ladies, also be for significant others, I think that's meant to be. So I mean, again, this is something that is about local decisions, I think, rather than national direction. Yeah,
I think so. And also remember, again, a lot of the local government services, they've had to cut back on other elements of the services, but the vast majority of local government services already have service provision for maternity, and some places that have it for partners. So those sorts of questions are the sort of questions that I think a local tobacco steering group or tobacco control alliance will need to answer, themselves, in the same way as, financial incentives. So financial incentives are not part of the NHS Long Term Plan maternity funding, but some local areas will be using financial incentives during pregnancy. So those are locally determined.
Thanks, Sanjay. And Paul, you've been flagging in the chat that the Stops Making Service returns also allow you to identify the source of referral. I think you're right on that. So that's another.
I think it's just most people default to self-referral now. but I do believe there is an option to choose NHS even.
Interesting, and I think that would, I mean, if we could encourage people to do that, would be quite interesting to see how that looks, because tracking what's coming into local government services would be useful to understand, you know, kind of looking at it from both sides. So I think this will probably be our last question. So apologies if we haven't managed to answer exactly what you wanted. And I do wonder again whether this is something that we might come back to look at in more detail. So somebody here from the mental health side flagging that you know that the mental health services may well look quite different from acute. I'm sure that's true, and that people are likely to be supported more on a temporary abstinence side and may well kind of disconnected with services by nature of the kind of client group or patient group. I wonder if perhaps it's something that we should come back to at a future webinar to spend a little bit more time focusing on the particular challenges of each of those different pathways, where they, you know, each mental health, maternity and acute all have different challenges. Unless you guys have got anything that you particularly want to add to the kind of nuance of collecting data from those patients within mental health services from any of the early implementer experience, perhaps?
Well, not so much. I mean, I just want to acknowledge the fact that the mental health data set is, you know, is nuanced, because, as you say, some people might, so a lot of the patients might stop whilst they're in the mental health trust as inpatients, but then immediately. So where do you measure the 28-day quit? And, you know, one of the things that we're aware of is when people leave the hospital environment and go back into their normal environment, all the triggers for smoking return. And that's why we're really keen on collecting a 28 post-discharge quit. And that was the reason. So sometimes I think, understandably, people are frustrated by some data that they're asked to collect, but pretty much every question that we've asked is for a specific reason. And there are pros and cons to asking questions, or what might be considered duplicate questions in different pathways. So it's just more of an acknowledgement that, you know, it can be a bit painful if you're the one collecting the data and you don't understand. But that's why I would say, look, please come back and ask any of us in the team. I think I just saw something in the chat, Hazel, about FAQs, and can the answers in this webinar be used? And I wonder if this is one of the webinars where we write up the FAQs, as it were, sooner than later, because I think there's just going to be loads of questions on here.
Yeah, and I think just to close, as we've got the last few minutes, you know, this is not, we've like closed the chat and you can't ask any more questions. You know, keep sending us your questions either through the you know, to me, to the Smoke Free admin email address, or to various other people have posted email addresses in the chat, and you know, we need to kind of keep collating those questions and identifying what the answers are, but also coming back to have a more detailed conversation about those things that won't be determined nationally, that will require either, you know, trust level solutions or ICS level solutions, you know, that we want to kind of keep having those conversations. So you know, send us your kind of tricky problems, your questions, and as both Sanjay and I have said, the examples of you know, where you locally maybe have kind of grappled with some of this and perhaps found some of the answers, so that we can kind of try and bring that all together in a future session. Thank you so much, Paul, Tom and Sanjay, for your questions. I have learned lots more about the data collection process today than I previously knew. Hopefully it's been useful for everybody else as well. And as we kind of continue on this journey of rolling out these new services and making sure we can understand, you know, what impact they're having and how we can continue to make them ever better. So thanks everybody, and this is au revoir, I guess, for metrics. We'll be back in about a month's time, I guess, to have a follow-up. Thanks everyone.